Thank you so much. Thank you for having me. Thank you for organizing such an amazing workshop. So as Frederick said, so I'm going to talk a little bit about implementation aspect of medical AI, and I will give you two examples of two of the projects that we started all the way from beginning to implementing and assessing its impact in the clinical setting. So in the US, I'm sure you are well aware of it, after 2007 economy crash, because of the incentives that Obama administration put in place, most hospitals would get some money to switch to electronic health records, and they actually started to switch to certain electronic health record systems that would cover a lot of aspects of capturing the data. And at the time, there was this one big company that was offering it, which was called Epic. And after, because of that, most hospitals started to switch to Epic. And by now, almost all the big hospitals have switched, even those ones that had in-home, homegrown EHR systems kind of slowly switched to Epic at the moment. A lot of people complain about it. However, it is a unified system that is spanning across a lot of institutions. NYU completed its own transition in 2013. And since then, let's say that from that point on, the data started to become more or less unified. And okay, now it's 2023, about 10 years worth of data. It covers about 8.5 million patients, and it ever grows, and it has a vast amount of diversity in terms of its data that is being captured. I'm showing here there's electronic health records, which includes labs, diagnosis records, medical notes. Then we have images, which down here is kind of just a breakdown of what kind of numbers do we see in our PAC system. And these are scans that have already been captured, along with a lot of information with them. So this is really a wealth of knowledge and wealth of resource that is sitting in the databases of our systems. And that kind of makes NYU, I guess, a learning health system, because we can utilize this data to drive new methods, approaches, findings, etc. And so I guess NYU is a locally situated hospital. And I was just chatting with Frederick that even within the US, exchanging data between hospitals is still not as developed. There are a lot of efforts towards that, but still most of my research and a lot of people's research is locally based on local institutions' data. And NYU has a quite large footprint in New York City. So if you want to start thinking about just breakdown of across different diseases, what diseases are we talking about? So you can see in red is the number of unique patients who have had certain families of diseases. This is at the very high level. You can break it down further and further. And then you can start to think, envision whether or not there are interesting questions that could be studied with this amount of data. Let's say that cancers, neoplasm, there's been almost like 500,000, a little bit over 500,000 patients who have visited and got received care at NYU. And so obviously they're going to have a lot of data. I will include some study about dementia early identification, where we look at some MRI data from our Barlow Center, which is a memory clinic, specialty memory clinic, as well as a broader NYU system. So this is an amazing resource. Every day a collaborator comes in from one of these subspecialties, and then we look at the data, and many times there are really a lot of feasibilities in terms of doing interesting research. So I guess the goal of all of us here is improving patient care, and there are many ways we can kind of go about it. We can focus on clinical decision support tools that are offering things to clinicians or things to patients. Like most patients at NYU now have this thing on their phone called MyChart. You can kind of work with them, but there are regulations that you need to be aware of. Then we can also focus more on just deriving new guidelines and data-driven evidence, which would at the higher level kind of change medicine and improve care. And there's also a lot of use cases in terms of resource allocation, just improving the operations of the hospital to be able to service patients better and in higher quality, etc. And then there are so many sub-approaches within it. And each of us in this workshop are amazing researchers. The morning session was also full of amazing talks, which addressed various aspects that could lead to improving patient care. Now, in my side of the things, I focus a lot on offering clinical decision support to clinicians. And in that field, it's a very rich field, but it's a field which is full of success stories on paper. But then when you actually start to look and say, okay, how much actual patient care changed based on either of these several models that are coming out day after day, and they're like known to be the most amazing AI research, like how many of them actually ended up changing patient care? And that's kind of the question that is very important to me. I'll give you an example. There are during COVID, for example, there was so many research coming out across different fields. So this is one of our own studies. At the time we studied it, we looked at peer-reviewed COVID models, and only one of them underwent prospective validation, and then none of them even were assessed in terms of did they actually make any difference in terms of care or not. And usually we can assess them through like randomized controlled trials, etc. Like that's a scientific way to assess them. So like nothing really made it all the way to RCT. Our study was the first to actually do that, and I will talk a little bit about it. There were so many imaging models on COVID. None of them were implemented, zero. And today, up to this date, I don't know if there is any imaging model for COVID that actually is implemented. And so, and then there's also a lot of other systematic reviews that look at these things. And there's really a big drop from papers on retrospective data showing amazing potential and then going all the way to patient care. So what is missing, right? So I guess we have the clinical problem, a lot of us start to tackle it, and then the goal is wide adaptation and hopefully patient care. But like the path, it's actually has a lot more than just the modeling part. And this is something that I also learned after like 6 years of being at the medical school. I really have started to be a little bit more familiar with the rest of the process. So I try to convey a little bit about it. So obviously the problem definition actually is by itself a big part of it. So many times non-experts define the problems, and then the problem actually is not very useful. And we come into the hospital and we say, okay, here's our problem that we have solved, and they're like, they don't know what to do with it. There's no use case for it. So that problem definition and defining actually exactly who are the patients, where the data comes from, who owns it, etc. These are questions that, okay, you typically involve most of even up to the paper and publications of all these retrospective studies. And that's kind of where things usually end, which is like we publish a nice paper and that's it. But then taking it to deployment, doing prospective validation, and then after that, considering regulatory approvals, FDA, etc., educating your clinical users, clinicians in our case, maybe patients, etc. These are all elements that definitely are very important. And then if you're really great, if you want to be really good in our research, we actually want to show with and without this tool, really what is the value added of this tool, right? So it would be ideal if you would apply some randomized trials to actually assess the impact of our tool. Okay, then this is very US specific, but like now, if we show that this thing actually works, insurance comes into play. Who is going to pay for it? And you need a code for it. Like it's like quite a lot of process, and then update clinical guidelines in all the top journals. They all have to kind of say that, yeah, we need this, we need this, we need this, and finally insurance starts to cover it, and that leads to adaptation. Okay, so this is a very, very long process. It takes like so many years to even like go from there, from beginning all the way to the end. And we haven't even gotten to I have never gotten to the point of CPT code. However, at least we have gotten to the RCT elements today. And I will talk to you about that up to this part, some of the lessons that we have learned. And yeah, hopefully it will be interesting to you. So one story is, so I guess for your information, when I first joined NYU, I was doing mostly up to here. And then 3 years into my faculty position at NYU, COVID started to happen. And New York City was one of the first cities after China and Italy. Like immediately it was New York City that got hit. And so we had to quickly, help in many ways. And that actually kind of was a very fast learning curve for our team to actually just be ever put into the situation, and we had to learn all the way up until here. So that was kind of a 9 months rapid learning for a lot of our collaborators and this big team to work together to get to that point. And now that we know how to do it, I'm doing it for all my research that kind of went on pause before COVID. And then after that, everything kind of got unpaused and resumed working. And now that we have this skill, we kind of apply it to all of the projects that we have. So this is a story of what could we do for COVID, okay? And so this is one story I'm going to talk about. And then before COVID, I was working on dementia early detection. And then obviously I took a pause of 9 months-ish to really focus on helping the hospital with COVID patients, etc. After that, I apply all of the things that I learned, and I will tell you now to this other project, which is about early detection of dementia. Okay, so these are the two things in the talk. So let's first start with looking into this first, I guess, pipeline from modeling all the way to implementation, which was a validated real-time prediction model for predicting favorable outcomes in hospitalized COVID patients. So what do we mean by that? So this is our co-author. When COVID hit, the first few weeks, there was so much uncertainty about everything COVID. They would just look into bioRxiv, medRxiv for any paper that's coming either from China, Italy, wherever they have some patients, to see is there anything they learn to care for the patients better. Week by week, day by day, the type of questions that were relevant in healthcare in that setting would change. So we as modeling teams would partner with clinicians. The first week, the first few days, we didn't even know how to test for COVID properly, at scale and in a fast way. Testing would take long. So there was a lot of interest. Can you identify who has COVID from the symptoms that they have? But within half a week, we were able to, NYU at least, was able to have an in-house testing unit, which would do the test within a couple of hours. So that question really didn't become relevant anymore. We built some models, but we left it there because there was no clinical use case within half a week. Then the ED folks came and say, okay, yeah, we don't know who should we admit to ED, etc. Can we build some models for that? And okay, we are still in the first few weeks of COVID, so we don't have a lot of patients if you think about it. So maybe like every day, like 50, 60 come in. So the first few weeks, we're talking about a couple of 100 patients. There's not a lot of fancy models we could do. Simple models we would try. And then who should be admitted from ED turns out to also not be super relevant within a week or two. The ED people were like, okay, no, the COVID trajectory is slower than we thought. And we really never had the problem where we send the patient home and they would contact us again. It's not a big important use case. And by the way, our beds are getting full, so we don't even want to admit people who can be home. So that use case, we built some models, but it was also not very useful. And then there is a lot of models. There are so many papers on predicting who is going to have adverse outcomes once hospitalized. However, it's also kind of surprising to know that our collaborators were like, look, we are doing everything that is published as the best thing you can do, or whatever we can do for everyone. There is no extra thing we can do if you tell us if this patient is going to deteriorate or not. This use case actually also is completely not actionable. We are already on full 100% alert mode for everybody in our beds, which is true. That was a crisis mode in like the first, like March, April, those months. Actually, you can kind of see the peak started to go up. And like the first week that we started to completely go virtual, the things happen was, I think, mid-March. Okay, so by April, things are kind of a little bit crazy. Everybody is in high alert mode. There is no value, according to our clinician, that if we alert them that this patient is gonna deteriorate more, there is nothing extra they could do. However, there was finally one use case that actually would be useful, which is who's safe to discharge from the hospital. Once they kind of pass the peak, how do we know when are they kind of okay to go home now, or because we also don't know that part of the trajectory of the disease. And this is a use case that's actionable. It helps us with planning, etc. So as you see, even defining the clinical problem that is relevant was an iterative process. We kind of threw away so many different thoughts that came along, and very quickly a lot of questions become irrelevant, and that applies even to today's healthcare, I think. So that's kind of okay, the story of why we ended up with this. And once we have the problem definition, the modeling part is actually kind of the easy part. And we have the patients that are in the hospital, they are, as I said, they are 100% fully cared for in the maximum way possible. They would get all these labs every 12 hours, I think, every 6 hours actually. And then so we would have a data without much missing data of a lot of rich biomarkers that were known to be important and a lot of utilization events. And then the task itself was predicting whether in the next 96 hours, is there gonna be an adverse event? What is adverse event? Like some serious situations like ICU transfer, intubation, and if they got discharged, coming back to ED, if they would like be discharged to hospice, meaning that they are on the trajectory for comfort care towards eventual death, and then mortality, and then these requiring a lot of oxygen. These were considered our outcome. And then so from beginning, we knew that this model needed to be implemented, otherwise there was no point in it. So how do we think about that? So this model is live, real-time model. So for a real-time model, connecting the plugs into the data elements is actually quite hard. It takes a lot of work per variable to pull them out. So our collaborators suggested, hey, we can condense the model. First, let's build some model of all the variables we have. Then there are some values that we can kind of, there are some methods that we can use to condense the model into a smaller model that's easier to deploy into Epic. Turns out that model actually has some better generalization properties too. And so that's what we did. The original variables were 65 variables. Based on this approach, we were able to condense them. And at this point, we are talking about 2,000 patients. This is, by now, this was, I think, April-ish, kind of almost like at the peak when we kind of circled through a lot of use cases, and this use case turned out to be useful. So we had about 2,000 patients for training, 600 patients where their data was used for validation, hyperparameter tuning, etc. And then we looked at the final performance on another 600 patients. Originally, okay, with this amount of data, there's not, again, a lot of fancy modeling you can do, but there are good models out there that are scaling to this level. And we use that one. So that's our black box model, like XGBoost approach, like GBM, random forest, logistic regression, ensemble of them. And then this model could be condensed into a logistic regression with exactly the same performance, with much fewer variables. And so that's kind of what we did. And then this is our AUC curve, and this ROC curve, and this is a precision recall curve. And usually precision recall curve is where we make a lot of decisions on our operation threshold. So we opted for 90% positive predictive value, meaning 90% precision. So what would be the recall and what would be the threshold that would give us that? And that's kind of where we use the cutoff for identifying people who, we call them green, they would be shown as green, like score, so that doctors would say, okay, this patient is on a good trajectory now, stuff like this. And so up to here, it's still retrospective. We kind of pulled the data on a daily basis. We would get the data. However, it was retrospective in its nature. And then we kind of, once we were happy with building the model, took us a couple of weeks to kind of refine all of the choices, etc. Then we needed to focus on deployment. So now retrospective, as I said, is a lot easier in many ways. So, and then prospective, which is plugging the data into the system, plugging the model into the system, is totally kind of different story. So live data in NYU and in most systems which are using Epic, most hospitals that are using Epic, there's one database that's live. It's not even a transactional database. It's a weird mumps-based database. It's like super ancient, but it's fast. Then by midnight, this database kind of gets dumped into another database, which is what we normally use, and which is typically built within the hospitals for researchers to access, because they don't want to overload the actual database. And then by 7 a.m., that other database also gets kind of dumped into another database, which would be a lot more, the structure would be a lot more unified across hospitals. That database is called Caboodle. Like this Clarity database, which is the midnight one, could be different between NYU. It could be very different between NYU and like Columbia and Harvard, etc. Whereas Caboodle is somewhat more unified. But so a lot of our labs during a retrospective study, we just pulled them 7 a.m. in the morning. However, now we need to plug them into the live database. So what do we do? There's, I guess, just keywords for you, but there is some mechanism we use, very tedious reporting workbench, which allows us to pull one by one these variables that we want. And then the model kind of lives in the cloud. These variables kind of go into the Epic cloud, get scored, and then the scores get put back into some other table in Epic. And then you can kind of show that in some different ways to the clinician. We showed it in two ways to the clinician. One is like patient list, which is how clinicians kind of do their work for hospitalized patients. They have this panel, each row is the patient, and there are a lot of information about it. We added one column based on our model, and the model would run every 30 minutes, basically, every 30 minutes a new score. And then we would kind of, first of all, show the trajectory of that score, the past several scores that has been scored. If they were not safe for discharge, we would show them as red, otherwise we would show them as green. And then we would also show them factors that contributed to this score, some kind of explanation, so that hopefully that would help, I guess, demystify this model to some extent. And then if you hover on these scores, there's even like a little bit more visualization of these ways that contributed to the score. We try to do our best within the capacities of Epic. And this is the other way that they could see it. This one doesn't have all the interactive features, but each patient has this summary report, which includes all the biomarkers that they needed, or like they that were useful to capture, whatever results they may have. And then also our model has also a card in this one to kind of show them at this time point what's the risk for, I guess, how likely is it that the patient probably is not going to have an adverse event within the next 96 hours. So we started with the perspective. We did some prospective validation after deployment. We scored several patients, and then we were on a fast track. We had to help in some way. The hospitals, we kind of got this model was developed and deployed when the peak was happening. And during the peak, all the 7th-floor ICUs that NYU had provisioned were filling up. That's why there was urgency to help in terms of, if there is a possibility to discharge a patient early to admit another more urgent patients, let's do that. So we did prospective validation over 2 weeks now in May, like after deployment, etc. The chart review was happening by clinicians and also medical students, and we also in the meanwhile set up the randomized trial, because we also wanted to assess how well does this model actually make a difference in terms of, I guess, discharge planning, etc. And So by May 15, the prospective evaluation actually turned out to be very successful. We were really, there was no issue in terms of the scores, zero issue. And then the live performance, we went live with the institution-wide email and seminars, etc. on Friday, May 15th. We sent the email from the MCIT. We kind of went on campus-wide presentations at different units, different hospitals, to educate the clinicians. And then we also continuously monitored the performance. And we also, for safety, chart reviewed all of our all of the readmission and mortality of any patient that was scored, regardless of which RCT arm, to make sure that somehow it wasn't related to the model. That's a safety arm of our randomized trial. And so continuous monitoring turned out to continue to perform well. We could monitor. So we had an automatic continuous monitoring. So every time we would do the prediction, we would cache the prediction that we did. And then 4 days later, 96 hours later, we could actually look at the ground truths, and then we could measure how well we did. And then, so the RCT, how does it work? So we had the hypothesis, the intervention was that we are showing this score to the clinicians. And the outcome that we wanted was from the first time the patient turns green until the discharge, we hypothesized that we are gonna reduce that length. Okay, but did we, so we registered a trial in advance, we do all the sample calculations, and then based on our sample calculation in May, we would complete the conclusion in January. We still had the model running, and it was running for half of our patients, but it would take a while for us to actually get the RCT result. And we got a result. We were kind of sad that at the end of the day in January, there was no effect in drop. However, the first few weeks, the first 10 weeks, which is when the COVID was much more urgent, there was half a day of improvement in terms of the discharge, and primarily about planning it, doing all the paperwork that needs to be done, calling patient, caregivers to come for pickup. Those things take a while. If you know to start them in advance, you just save half a day, more or less. And then we also surveyed the clinicians, and it turns out that the model actually led to a lot of, primarily it led to less uncertainty and giving them better ability to plan and prepare for discharge. Okay, that was the value added of our model. There was really not a case where the clinician would be surprised by the prediction, things like that didn't really happen. So yeah, that's the story. We got up to here. We didn't get a code or anything. And we shared the model. But at that point, the urgency of COVID in some way kind of gone down. So we didn't get to wide adaptation. Hopefully with other stories that we have, we kind of get to that point. And so that was a very fast, crazy couple of months for us. We learned so many things.
Narges, if you don't mind, I'm just going to ask the audience if there are any questions about the first.
Yeah, okay.
Is this a good time?
Absolutely, okay. Absolutely. Yeah, so, I wasn't sure how it works. Yeah, tell me.
Yeah, sure. Are there any questions about the first project here on the COVID response from the audience? If not, I have one.
Sure.
So I was curious about the RCT that you did with the clinicians. Were the same clinicians exposed to both the system and the not system, as it were?
Yes, they would. So I didn't have the slide here, but like the way they would see it is in the patient list. Sometimes for these patients that were in the control arm, we would just say hidden, or we would tell them, look, sometimes for some reasons we are not going to show you the score. We didn't tell them it's RCT or anything, but yes, they were, it wasn't a clustered randomized trial in some way, and they could see it, but yeah, that's kind of
did they report missing it? Because you said that they appreciate the qualitative result that you showed in the end. They're kind of indicated that they liked having it for planning. So
for the first few weeks, yes, it helped them with the planning, and but no, it's not like they were totally missing it, to be honest. So it was not like they were very angry that we didn't show them for everybody. But yeah, it did help. Our RCT showed that if there is an urgency for bed supply, which was early in the summer, model actually helps. Afterwards, it didn't make any difference because, okay, we had extra beds, so nobody really was in a need to like do things more efficiently, I guess, in some way. But yeah, this is a great, actually, my other studies now moving to dementia are now in form of randomized trial so this one will be clustered randomized trial. I understand what you're saying, that maybe just exposing the clinician to the model will just change their behavior, and that may lead to certain outcomes, and it is true. So in the other study, we are doing it at the clinic level. So some clinics are going to be exposed to the model, some clinics are not going to be exposed, and then we will compare them. In that way, it's a little bit more realistic. And that's a great question. So, okay, now almost 9 months, kind of, we were busy in our entire team with completely forgetting everything else in our research portfolio and focusing on COVID, but then kind of things got a little bit better, and then we went back to our lives, which was, before COVID, I had been working on early detection of dementia. But now all the learning that we had, so we got more ambitious in terms of moving towards clinical impact, and we had a little bit more tools in our kitchen sink now. So this part of this is already published, part of it is still ongoing. It's a very long process. So we, at the time that COVID happened, we were just in the midst of building models that would identify dementia early. Why do we care about this? So first of all, dementia, there's no drug for it. Every clinical trial has failed at the moment. At some point, they learned that we need to identify it early and in mild and moderate stage. Even beyond that one, don't even bother with clinical trials. That's too late. The amount of brain tissue loss is just too much. You cannot reverse it. You cannot grow brain. All you can do is slow down. So it's very important to identify things early, not only for treatment, but also for even clinical trials. And then there are recent studies that actually show there are some interesting value in early detection. There are things you can do that by RCT at large scale, it has shown that it can delay onset of conversion to mild cognitive impairment and Alzheimer's dementia. One study is about hypertension control. Another study is underway about cholesterol management. There are things we can do if we know the patient is at high risk. And also you can do a lot of improved planning and caregiver support, etc. And obviously better enrollment for clinical trials. So that's kind of the goal why we are doing this. And also, I guess, not surprisingly, there's a lot of disparities in dementia early detection. 2/3 of the patients are women. Risk factors actually turn out to correlate with race and socioeconomic status. These are some high-level risk factors that seem to be, associated with Alzheimer's onset later. You can see like early life, low education, midlife, stressful things, and like alcohol, obesity, later in life, depression, etc. These are already also correlated with a lot of minority disparities in terms of their healthcare. And on top of that, most patients from these minority groups actually don't even get to be seen by neurologists. And even the tools that are developed for screening are not really refined for these populations. And they are mostly refined for educated, college-educated kind of populations. And there are studies like NAC and ADNI that are like these high international studies to collect a lot of data. They are primarily really highly educated, primarily white populations. Actually, like they forget about the main cohort that is at highest risk for dementia. This is terrible and it's unacceptable. And so we need to fix that. So we asked the question, well, there are so many ways you can approach it. One is looking at electronic health records to do risk assessment. And we're doing that, but I'm not talking about it in this talk. Another one is actually using more accessible modalities like MRI, etc., to actually identify dementia earlier and start, some things that are doable, at least offer these to these patients. So this was a question of, can we build a model based on MRI to identify these patients? And then, okay, now that it's post-COVID and we have learned a lot of things about implementation, can we integrate them into clinical settings, measure the impact, and then do these models eventually change the patient outcome? So obviously, the first part is the easy part, building the model, doing the retrospective validation. And we did that. We kind of did use two these very white, very educated cohorts that I complain about. But in the community of AD, you have to show something on these data sets. So we built some model based on one major data set. We completely externally validated it on another data set. And we did a lot of, innovation in terms of, not a lot, we did some innovations in terms of actual machine learning part of it. So like you cannot just take existing tools and you kind of need to adapt them for your use case in let's say in MRI. We learned some lessons in terms of AI part of things. And then we, here's the data that we kind of, as I told you, for the retrospective part, the first part of retrospective part we studied, it's not a large data set. We're talking about 2,000 something scans, but still the performances are promising. And so the performance, like identifying, let's only identify normal versus MCI or AD. Like just if somebody is at mild stages, they're either MCI or AD. So primarily that's what I care about, the CN versus the rest. And so that performance, pretty decent AUC. And then, as I said, we normally think about operational decisions based on precision recall curve. So this is class 0, that's a normal versus others. Class 0 is not too bad in terms of the performances on our retrospective, primarily white, well-controlled, well-designed research cohorts. And then, so yeah, if you are thinking about like 50% recall, that's kind of a reasonable setting for actions, interventions. Then we are talking about, 80% positive predictive value roughly across these two cohorts. 80% is not too bad. 4 out of 5 times when the model fires, it's actually correct. And that's useful. Okay, so okay, I will skip this one. We kind of compared it with a lot of existing tools as well. It turns out that deep learning is actually better. It can also even give you some kind of a future kind of outlook in terms of progression. If the model is even by error if the model predicts somebody who their ground truth label is MCI, but if they're predicted as AD, turns out that, okay, yeah, they do have a little bit, they are going to transition to more severe stages of Alzheimer's disease a little bit earlier. So there were a lot of good properties of this AI model on these two data sets. So now let's bring it to clinical setting, which is NYU. So we've got we started with the Barlow Center, which is our memory clinic center. And we got all the clinical MRIs from that center. Why did we start with that one? It's because, okay, those centers, at least the screening is a little bit more comprehensive. So we already know there are a lot of disparities and underdiagnosed dementia in overall population. So it's a hard problem to define clinically. But if you focus on the Barlow Memory Center, even if you focus on that, we already have a lot less, I guess, uniracial things. We have more diversity in our population. And then we have more female, etc. So definitely there's, compared to ADNI and NAC, the other studies, which were like 92% or 83% white. So there is definitely some good thing to even evaluate here, but obviously my aim is to evaluate it across the bigger cohort. So if we evaluate that exactly the same model on this cohort without any fine-tuning, just predicting, performances are okay. This is CN versus this is AUC curve, by the way, ROC curve. CN versus others. This is like more advanced dementia. There's some use case, but if you fine tune only the last layer, which I think it mostly corresponds to calibrating the probabilities, then we actually can already achieve a lot better performances. These are good. These are good performances. We can actually already start something with them. So now that this is where we are, and for the interest of time, actually, also, I don't have a lot to say because we are in the midst of it. We are deploying this model and we are doing prospective validation. How are we doing prospective validation? On daily basis at 7 a.m. So this one is not like real time. We have a little bit of wiggle room. We'll only do it once a day. We identify all the accession IDs, which is the image ID of any MRI that has happened at NYU Langone. So at this space, we are moving beyond Barlow Center, and then we score the model and we keep track of the group that are predicted as MCI and AD. We rank them according to high probability for AD all the way to, MCI stage. And then we push a PDF back into our PEG system. It's very ancient. I'm sorry, it looks like this, but that's what radiologists are used to, with the scores and the model explanations, and the reviews are some neurologist residents at the moment are reviewing the predictions, and then we are measuring the PPV. That's kind of where we are. And then this is a proposal that we have submitted, but we haven't done it yet, which is a clustered randomized trial. We identify, these high-risk patients are kind of sitting in a list somewhere, and when some of these patients schedule an upcoming non-urgent appointment with their primary care provider, if they are high risk, if they are scheduling something with the providers that are in the intervention arm, then that provider is going to get an alert that, hey, if you want to do a screening today, and by the way, this patient hasn't undergone any screening for a while and they are overdue for that, feel free to do it. We don't push anything to them. If they want to do it, they will do it. If they don't, they won't do it. So that's kind of the process that is currently being built up for the RCT part in the dementia one. And that's pretty much what it's like, a recipe now that we actually want to apply to most of our modeling. And so yeah, and all the red parts, the RCT, including it's stuff we haven't gotten to do. It's gonna take maybe 5 years for me to even potentially envision getting to the point of dealing with insurance and whatnot. But yeah, that is kind of some of the stories I shared with you. Take home message is the whole implementation goes way beyond the retrospective modeling. It's very interdisciplinary. It requires a lot of support from high-level executives. It's all these people's times. Somebody's paying for it, and typically it's the hospital that's paying for it. So leadership should be on board, and there are a lot of human factors involved as well. But also the COVID study taught us that it's doable. It's very hard, but it's doable, and that's the exciting part. So thanks a lot for listening, and if there's time for questions, I'll take it. Otherwise, I can also take questions online or stay after this, after next talk.
Awesome.
All right. Thank you so much, Narges. I hope you could hear the applause. Sometimes the mic just cuts out when you.
I saw it. Thank you.
You saw it. Awesome. So, are there any questions? Yes.
Can you hear me?
Can you hear Uri?
Yes.
So what kind of outcomes and follow-up are you looking for in the AD trial?
It's a screening. The primary outcome is screening itself, not necessarily the diagnosis. That's the primary outcome. It's already low for racial minorities, and that's our goal, that we want to increase the rate of screening at the PCP offices. But there are secondary outcomes. The secondary outcome is diagnosis of ADRD, the rate of diagnosis. And also in this study, as I mentioned, because there's cardiovascular interventions that actually are useful. So we are also telling to the patient that, hey, this patient isn't adhering to their blood pressure medication, or etc. If you want, deal with it. And if so, then we actually have cardiovascular secondary outcomes too, like the rate of poor hypertension incidents, A1C if they are diabetic, the rate of medication adherence. So yeah, these are the secondary outcomes.
Thank you.
Sure. Do you have access to any
Any what? Access to?
Do you have access to any genetic data for that cohort?
Great question. No.
ApoE
What's the
So-
last point?
ApoE status.
Yeah, ApoE status, for example.
No, not at NYU. So that's the thing where if you at NYU and NAC, yes, you have access to. However, I'm not super keen on using data that is at the moment not part of clinical practice, because if we do that, then that model is really not applicable in the clinical setting. ADNI and NAC do have ApoE4, so that is kind of, I guess, the answer to you. And I think there is some value. However, the rate of ApoE4 positivity is only like less than, it's 30%. Okay, even in AD cohort. So it's not like it's very predictive. And even in the control patients, we have like 28% that have ApoE4. So, it's very useful genetic factor. I am looking forward to more cohorts that come with this data. However, at the moment in the clinic at NYU, they don't do genome sequencing or even SNP sequencing for the patients. And because of that, we try to not use those factors until they become clinically viable. But yeah, it's a good question. And I think you're right. It does have some interesting predictive value, probably.
All right, more questions? Yep, over here. Yeah, we'll see if this works. Otherwise, I'll forward it.
Can you hear me? Yes. Or can you hear me?
Yes.
Okay. First of all, thanks a lot for the talk. Very impressive. I had a question about the trial on the discharge tool.
Mm-hmm.
So you said that there could be some learning effect for the clinicians that are using the tool, so that it would be probably better to do a cluster randomized trial. I was thinking there's also maybe one other thing to keep into account, that in some sense discharge is a departmental-wide intervention, right? So even if patient A doesn't get any score, but patient B does, my decision on patient A will be influenced by the fact that the patient
probably
has got a score. And maybe another way of thinking about this is that the pressure to the department will push make decisions, and then even the people that are not in the treatment arm will be influenced by the fact that some people actually get scores of some sort.
That is true. And so the way that the discharge works, I think from my understanding, is every morning the residents, everybody kind of does huddles. They get together, they kind of hand off patients, and this person says, okay, last night this thing happened for this guy, this thing happened for this guy, I think this guy is good to go, stuff like this. There's a lot of things that happen in that morning meeting, and then they kind of start planning their day. So yeah, there could be some, definitely I agree, there is a lot of confounding, I guess, or connections between the two arms, the way we have done it. I guess the effect of those would be that they would diminish the effect, right? If there is some bleeding between their arms, we get less and less significance in terms of the differences of the arms. And maybe that is explaining part of our lower, I guess, impact, especially after the summer, few months of summer went by. So these are good questions. We have the data, we could look a little bit into some of these hypotheses and evaluate it. This is a great point. I agree with you.
All right, one last question, then let's see over here.
So, given your amazing AD cohort for your observational classification, what's the possibility of enrolling them as clinical trial cohorts for intervention, even if they were open label?
That's a great point. So we do partner with Barlow Center, and they do refer to clinical trials. Is that what you're saying? That actually connecting these patients potentially?
And you could test intervention. That's almost, you're nearly there on the cohort.
Yeah, absolutely. And that's kind of the ultimate ambition. It takes so many build up to get to that point, I think. We need to first show that, okay, in the clinic, this thing actually works. But after that, I agree. I think that is kind of the way to go, connecting these ones to clinical trial enrollments. And we do have the mechanism inside the hospital setting to refer patients. there is some other hurdle that we have to address, which is racial minorities also don't like typically to enroll as well. This is a different problem, okay, than the screening itself. So we kind of need to maybe do some user studies and see how can we facilitate them enrolling in clinical trials as well. But that is kind of the ambition of this project, really addressing this failure of clinical trials over and over. Why is that happening? Part of it is early detection issues. So we can help with that. It's true. If you are interested in some collaborations like this, anybody, definitely we could form some interesting collaborations together.
Awesome. Thank you so much, Narges, and thanks everyone for your question. Let's thank Narges one more time.